All right, good afternoon, everyone. We're going to go ahead and get started on today's webinar. It looks like the time is now 12 p.m., so we'll go ahead and get started. My name is Morgan Anderson. I'm a health education specialist with Southeastern Idaho Public Health, which is Public Health District number 6, and I coordinate our drug overdose prevention program. I'm just going to take a minute, an opportunity to pass the time over to my co-presenters so that they have an opportunity to introduce themselves prior to us starting the webinar. So Mallory, if you don't mind, I'll kick it off over to you to introduce yourself first.
Thanks, Morgan. My name is Mallory. I work at Eastern Idaho Public Health. I coordinate our drug overdose prevention program and our opioid settlement program for Public Health District 7. And like Morgan, I'm a health education specialist. I'll kick it over to you, Wendy.
Hi, thank you. My name is Wendy Muir. I am the Program Information Coordinator for the Prescription Drug Monitoring Program that is administered out of the Idaho statute for the Idaho State Board of Pharmacy.
Awesome. Thank you both so much for those introductions. And we want to say thank you to all of you for attending our prescriber education webinar today. We're going to be talking to you about PDMP compliance as well as some risk management in Idaho. This webinar will feature 2 separate presentations, one that Mallory and I will be delivering, and then we'll pass it off to Wendy to go through PDMP and her portion of today's webinar. We will take questions throughout the presentation. However, we ask that you use the Q&A feature at the top of the webinar screen to enter those questions. We'll try to answer those as we can. And then also at the very end of the webinar, with whatever time we have left over, we'll also take questions at that time. So you'll be able to come off of mute and ask those questions then. Additionally, this webinar is being recorded, and so we will make this available to you after the webinar, as well as any colleagues that you know that may have benefited from this but weren't able to attend. We can share that with them as well. Before we get started, I am sharing my screen, so let me know if you're not seeing my slides, but this first slide is a QR code to a pre-survey for today's webinar. It really helps for us to learn about, what your experiences are, and also helps us improve these types of trainings for the future. So if you have a chance to scan this QR code, and we're also going to put that link in the chat as well. It just takes a minute or so to fill out this pre-survey, but if you could go ahead and do that for us, that would be great. But I'm going to go ahead and just advance into our slides. Mallory and I will do the first portion, which is going to be covering prescription drug dispensing trends as well as risk management in Idaho. So I do have a couple of disclaimers. So our first disclaimer is this publication was made possible by a grant that was awarded from the Centers for Disease Control and Prevention. However, the contents are solely the responsibility of the authors, so it does not represent the official views of the Department of Health and Welfare or the CDC. Additionally, Mallory and I have no other financial disclosures or conflicts of interest with the presented material in this presentation today. The learning objectives for Mallory and I's portion of today's webinar is to help build a stronger understanding of state and local overdose trends, prescribing data, as well as some emerging drug threats in the state of Idaho. We also want to explore ways healthcare providers and systems can support overdose prevention, as well as learn about local risk management resources that are available through the state and local public health districts. So first, let's start out by talking a little bit about some state-level overdose data to provide you with a little bit of context to why we wanted to, bring this information to you. In the 5-year period from 2019 to 2023, Idaho experienced significant increases in drug overdose fatalities. We had a total of an increase of 45.7% increase in all drug overdose fatalities in that 5-year period. We had a 27.4% increase specifically in prescription drug overdose fatalities, a 97% increase in opioid overdose fatalities, and a 756.5% increase in fentanyl overdose fatalities. We did, however, in 2024, see our first decline in drug overdose fatalities in several years. We had a decrease of 12.7% in all overdose fatalities, which came to a total of 337 Idahoans that lost their life to a drug overdose. Of those, 252 of them were directly linked to a prescription drug, which is 75% of all of those overdose fatalities being linked to prescription drugs. Opioid-related fatalities were 212, and then 128 were directly linked to fentanyl. And if you look at this right-hand side of this slide here, there's some demographic information that's included here. This data is actually public-facing, available to you through the Idaho Department of Health and Welfare's Get Healthy Drug Overdose Data Dashboard, which we will also link in the chat for you. But if you look at the demographics, it breaks it down by age group. And if you look, the age group 35 to 44 was the largest age group for overdose fatalities, with 95 of those. And when we break it down by gender, females experienced 132 of those, and male was 205. The state had a death rate of 16.84 deaths per 100,000 population. And in addition to fatal overdose data, we also wanted to share some non-fatal overdose data. So this is also available on the state's website. This is the 2025 Overdose Emergency Department visits. So we had a total of 3,798 emergency department visits related to a drug overdose, which was a rate of 5.6 per 1,000 population. The highest health district, which is Southeastern Idaho Public Health District 6, was 9.18 emergency department visits per 1,000. So when we look at the demographics on this particular data set, something that's kind of interesting and different from the fatal overdoses, the demographic age group changes. So the highest amount of drug overdose emergency department visits was actually in the 15 to 24 years old age group, with 875. Also, females were the highest patient for overdose, drug overdose emergency department visits, with 2,240. And male was 1,555. So kind of an interesting difference from fatal and non-fatal overdoses there. Additionally, we also have access on that website to 2025 and previous years drug overdose EMS runs. So in Idaho in 2025, we had a total of 4,659 EMS runs directly for drug overdose. The highest public health district in the state was Public Health District 4, which is the Boise area. So that makes sense. They had over 1,400 EMS runs for drug overdose. And also, it breaks it down and tells you how many of those overdose patients actually received naloxone. So there were 335 that received naloxone by EMS, and 158 received naloxone prior to EMS arrival. So in addition to those data sets that we have to share, we also wanted to talk a little bit about another data tool that we have available to us in public health, which is our overdose spike alert system, utilizing the overdose detection mapping application program, or ODMAP is what we refer to it as. It's a national program that uses geolocates suspected overdose to guide enforcement, intervention, and treatment efforts in a more data-driven way. So this program is used between law enforcement, EMS, and public health agencies, and they're able to, in real time, report overdoses in the system. So this allows for the Idaho health districts to work on setting up spike alert systems to serve as an early warning system if we do have any emerging drug threats or concerns in a specific population or community. And although overdose fatalities have declined from the data that I just showed to you, we continue to see spikes throughout the state using this ODMAP system. And so this really highlights the need for us to have sustained prevention efforts. So really kind of wanted to provide a little bit of an overview of what we're dealing with in terms of overdose fatalities. I'm going to turn the time over to Mallory. She's going to run through some emerging drug threats with you.
Thank you, Morgan. So as Morgan said, I just am going to talk about emerging threats. Primarily the threats that and the overdoses that Morgan and I work on throughout the drug overdose prevention programs at our two health departments focus on opioids. But we wanted to let you guys know of some things that are in the drug supply right now. So Morgan, if you could advance for me. These are ones that are in the illicit drug supply. Obviously, illicit substances are different than the ones that physicians you guys as physicians or providers or working in an office are prescribing, right? Xylazine is actually a veterinary tranquilizer. It has been found in the illicit drug supply, and they have found it in the drug supply in Idaho, and so that's why we just wanted to make you aware of it. It is not an opioid, so the medication naloxone, or also known as Narcan, that you may be aware of that helps to reverse an opioid overdose, does not work to reverse the overdose symptoms or the sedation of xylazine. What it does, it increases the amount of euphoria that somebody feels when they're consuming that illicit substance when it has the fentanyl in it. But like I said, it continues to sedate the body system. So if you go to the next slide, it actually shows us that from January of 2019 through May of 2022, in the United States, we had a 276% increase in illicitly manufactured fentanyl-involved overdose deaths that xylazine was detected in. And again, this is a non-human substance. It's a veterinary medication, but just one that we wanted you guys to be aware of. And then the other one is medetomidine. Xylazine also, just so you guys are aware of, creates really bad ulcers on the patient's body. So on top of the overdose risk, it's really hard, the wound care, trying to treat that. Okay, sorry, Morgan, go on ahead to the medetomidine now. And medetomidine is another drug that has been found in the illicit drug supply. It was primarily found in Philadelphia in the beginning, but it has been found in the drug supply in Idaho. It also is a non-opioid veterinary sedative. Unlike xylazine, it's actually 100 to 200 times more potent than xylazine. It also, like xylazine, does not respond to naloxone. So just something that we wanted you guys to keep in mind. Though these are veterinary medications, these are being put into the illicit drug supply because individuals are looking for the different euphoria, and just something to be aware of.
Awesome. Thank you, Mallory. So the next few slides, I'm going to run through some Idaho prescription drug data, dispensing data, which this data is available. It's public facing through the Idaho Prescription Drug Monitoring Program data dashboard, which is maintained by the Division of Occupational and Professional Licenses. We will also link this in the chat so you can go check it out for yourself. But this slide shows the 2025 top 5 controlled substance dispensing counties in Idaho. So our top dispensing county was Caribou County, which had a dispensing rate of 241 controlled substances per 100 people, followed by Bannock County, Butte County, Bonneville, and Bear Lake County. Now, if you're in the southeastern Idaho Public Health District 6, I just want to point out that 4 out of the 5 top counties in this category are within Public Health District 6. So we have kind of a high prescribing or dispensing rate in our area when we look at the entire health district. And this map here shows you all the counties, and then the darkest shade of red represents the highest dispensing rates, and then the darkest shade of blue represents the lowest dispensing rates. So you can kind of locate where you're at and see where your dispensing rates line up. So this next slide is specifically looking at opioid dispensing rates by county in 2025. Our top opioid dispensing county was Shoshone with 103, Benawah had 99, Lewis 89, Caribou 89, and Lemhi 87. So again, if you look at the map, there's a lot of red on here, which indicates that we have high amounts of opioids being prescribed. And when we compare these opioid dispensing rates to, say, like the national opioid dispensing rate, it is closer to 40 opioids per 100 people. And so there are several counties throughout the state of Idaho that have high dispensing rates, which is really driving up the risk in the state of Idaho. I also wanted to point out the top 5 stimulant dispensing counties. So Bonneville, Ada, Bannock, Jefferson, and Fremont. We have some high dispensing in those areas. And then also wanted to share the benzodiazepine dispensing counties as well. So Caribou, Lewis, Butte, Oneida, and Bear Lake County. all in the top 5 dispensing counties. A lot lower rates of dispensing for benzodiazepine as, say, like opioids, but still something to be aware of, because if we have these prescriptions circulating in the community, that is adding to that risk of overdose. And just kind of going back to one of my earlier slides, in 2024, 75% of all fatalities, overdose fatalities, were linked to a prescription drug. So now that we've shared a little bit of the data and what some of the issues are we're experiencing, now we're going to transition and talk about some risk management resources and just risk management in general. So I'll let Mallory take off with that.
Thanks, Morgan. You can go ahead and proceed to the next slide. So when we're talking about risk management, there's a few things we want to focus on. One, if you have patients who are taking opioids, some things that you guys can do to reduce the risk is, one, educating the patients about the risk of opioids. These slides are opioid specific, but making sure really if there's any prescription being prescribed, making sure there's that education, but especially with opioids, what are the risks involved with them? And then checking the Idaho PDMP prior to prescribing opioids. Those can help mitigate things like patients who are receiving opioids from multiple prescribers, maybe a high total daily doses of opioids, different medications that could be conflicting to each other. So being able to check that PDMP helps to mitigate some of those risks. And then what you can do as well is encourage safe storage and disposal. And Morgan will talk more about this, but there are resources that we have in Eastern Idaho that help encourage safe storage and safe disposal of any prescription medication, but especially of prescription opioids. The public health districts have different options for those. And then there's different guidelines. So one of them is the CDC guideline for prescribing opioids, making sure that you're familiar with the guidelines from the CDC on opioid prescriptions for chronic pain. This next slide talks about what you can do regarding risk management with individuals who are opioid naive and how to minimize that exposure to opioids. So if somebody is opioid naive, you can consider non-pharmacological or non-opioid pharmacological approaches to pain management. There are alternative pain management options, things like massage therapy, physical therapy, cognitive behavioral therapy, over-the-counter medications, just different options that they have. And then if you do prescribe an opioid for acute pain, prescribing the lowest effective dose in the beginning instead of a higher acting dose, and giving no more than what the expected duration of the severe pain should require. And then also, again, referring to specialty-specific prescribing guidelines for other dosing recommendations. Next slide. And then for patients who are currently on opioid treatment, decreasing the risk of overdose death looks like things like educating that patient about the risk factors that would increase the risk of overdose. Maybe if they're combining medications with alcohol, or are they taking multiple different medications that would sedate the body system? Do they have different medical conditions like sleep apnea or COPD that may increase the risk of respiratory depression? Have they had a history of substance use? Educating patients and talking to them about if they've had a substance use disorder or a mental health disorder are some of those things that we can do. And then minimizing that high-risk prescribing, so be cautious when increasing doses. And then avoiding the concurrent prescribing of benzodiazepines and other sedating medications with prescription opioids. As prescribers, you can co-prescribe naloxone. In the state of Idaho, we do have a program that provides free naloxone to anybody in the state. Naloxone is also available over the counter. We have seen that now that it's available over the counter, some insurances are no longer covering the cost of naloxone, or they're not covering the full cost of naloxone. I was informed today that Idaho Medicaid is still covering the cost of naloxone, and an individual with Idaho Medicaid can get naloxone for free. But checking with them, offering to co-prescribe naloxone if you think they have high risk of overdose, maybe if you're concerned that they might forget the last time that they took their medication, or if you know that maybe they've told you that they drink alcohol or just have other high risk factors. and then consider tapering on a case-by-case basis based on different guidelines. Next slide. And then reducing the stigma is an important part when we talk about opioid use disorder. So stigma is attitude or belief that looks at somebody a certain way. It's socially discrediting and thought to be different barriers. So SAMHSA told us in 2018, some of their data shows that of the 21.2 million people 12 or older who needed substance use treatment, only 3.7 million received it. So a lot of people don't seek treatment because of stigma. So reducing the stigma by educating staff on what addiction looks like and how addictions and dependence, how that works, what somebody would look like, or how that affects the body system, promoting the understanding of opioid use disorder as a medical illness, and then adopting appropriate non-judgmental person-first language. And we talk about person-first language, it's putting the person before the diagnosis. So an example of that is instead of saying a user, we call somebody a patient or a client. Instead of a former addict, a person in recovery. So when we can reduce the stigma, it will make it so that people might be more willing to open up to you about if they've had a substance use disorder or about their substance use. So that way, when you are prescribing them medications, you'll know if there's other risks that you need to be aware of.
Awesome. Thank you, Mallory. So just to finish up our portion of today's webinar, I'm going to run through some risk management resources that the health departments, both state and local, can actually help out with when it comes to risk management with your patients. So Mallory kind of already touched on this a little bit, so I won't spend too much time, but naloxone access, she mentioned that a lot of insurance is no longer covering naloxone, which is really unfortunate because it's a nearly $50 out-of-pocket cost if somebody goes in to get naloxone. And so fortunately, the Idaho Department of Health and Welfare implemented a full free naloxone distribution program that organizations, residents can order directly from for free, as well as some of the local public health districts. Some of them also offer naloxone for free. So naloxone at this point is widely available, and we encourage healthcare facilities, pharmacies, and just community organizations to have naloxone available in case of an emergency, but also explore maybe distributing it to your patients that are at high risk as well. So if you're interested in obtaining naloxone to hand out for free in your organization, you can scan this QR code and it'll take you directly to the state's naloxone order form. Additionally, fentanyl testing strips are another tool that can help prevent overdose in Idaho. And as of July 2024, the Idaho Code actually made these to where they're no longer considered illegal. So it removed their classification as drug paraphernalia. And we know that fentanyl testing strips, the evidence to date shows that fentanyl testing strips lead people to change their behavior without actually increasing their risks. So if you're interested in fentanyl testing strips, or you want to refer people to use fentanyl testing strips, they can actually order those directly through the Idaho Department of Health and Welfare's naloxone distribution program. There's an option to order fentanyl testing strips in addition to the naloxone. And then on top of naloxone and fentanyl testing strips, other simple tools and resources that are available are things like safe medication storage supplies. So we oftentimes hear from people about their methods of storage, and that's really something that we really want to educate the community about. So we really encourage you to speak to your patients and encourage them to lock up their medications, keeping them in a secure lockable cabinet or in a medication lockbox or pouch, and then just monitoring doses and supply throughout the duration of that prescription to make sure that no double dosing is happening, no medications are disappearing, and easy tracking tools can be used, like pill organizers. You can find these at most pharmacies. You can find them at the dollar store. And then as well as timer caps. These are another really great tool that tell the person the last time they opened that medication bottle. A lot of these resources are available for free through the local public health districts. As well as storage, disposing of medications is really important. A lot of people don't know what to do with their old medications. So we really suggest encouraging patients to get rid of their old expired unwanted medications instead of holding on to them. So patients can dispose of medications by following the disposal label, instructions on the label if they're included. A lot of times they're not, so patients can also get a drug deactivation or a drug disposal system, like these doTERRA packages that are shown here on the slide. There's other brands like Dispose RX. These are just a safe way for people to neutralize their medications and safely throw them into their household trash. We also recommend using the gold standard of drug disposal, which is utilizing drug take-back locations. It's just the safest way to get rid of medication. So usually these are located in pharmacies or law enforcement agencies. So if you would like to locate where all of those are at in your area, you can scan this QR code and it'll take you to a locator for all of those drug take-back locations throughout the state. We went over a lot of resources that are available to you. So if you're inside District 6 or District 7, you can reach out to Mallory or I. But if you find yourself outside of the southeastern and eastern Idaho area, we've included all of the health districts as well as their drug overdose prevention program coordinators. So if you're interested in these supplies, find out which district you're in and reach out to your local coordinator, and they'd be happy to connect you with some of these overdose prevention supplies that you could potentially even have right there in your facility, in your practice, so that you can provide to patients or clients. That's all Mallory and I have. Thank you so much for listening to our portion of today's presentation. Again, we're going to save questions for the end, and I do see that we have some in the Q&A, so we'll try to get those answered. But I'm going to, at this time, turn the time over to Wendy so she can go through her portion of today's webinar. It's all yours, Wendy. And it looks like you're on mute. I'm not sure if you're talking.
Yep. Gonna get to my presentation so I can move it into slide mode, which it's not doing. Okay. There. Okay, one moment. Come on. Go. Okay, can you see it now? All right.
Yep, looks good.
Okay. All right. It is a pleasure for me to talk to everybody here today. I was very excited to be invited. I do feel that the PDMP is a pretty important program. I know for prescribers, it can be a time-consuming process in your day. So hopefully I can give you some tools and tips here today to help you understand how important this is and how more easily to use it. So I've got to put out some disclosures and disclaimers. I have no conflicts to disclose today in relationship to this presentation. Today's presentation is briefly highlights some of our laws, but it is not a substitution for reading the law in its entirety. So today I'm going to discuss some Idaho law, and then I will segue into some mandatory checking and show you some checking rates, and then show you some tools and strategies, and of course we'll have a Q&A. So I'd like to just briefly touch on some terminology that we use within the program. PDMP or PMP are common terms. PDMP, Prescription Drug Monitoring Program. Our vendor commonly, they use the term PDMP, so they do get crossed over. They mean the same thing. AwareX is the name of our vendor's program where the PDMP accounts are housed for our individuals and for our drug outlets. The information within the system is protected, and data can only be shared per statute with specified individuals. And PDMP programs do exist across the nation, but they're not all regulated by the state boards of pharmacy. Many of them fall under the jurisdiction of health and welfare and various other regulatory agencies. We do have legal agreements that we share prescription data with other states. What this basically means is that a prescriber can query prescriptions filled in neighboring or other states while searching the PDMP for Idaho prescriptions. So the Idaho law, we've got a couple of things that apply. The Prescription Drug Monitoring Program is governed by various laws established by the Idaho State Board of Pharmacy. These laws not only establish the program's framework, but also require individuals to register for an account and use the service. Furthermore, certain laws require reports to be submitted to the program. For example, Idaho Code 37-2716 requires every person who manufactures, distributes, prescribes, administers, or conducts research with any controlled substance to register for a practitioner-controlled substance registration with the Board of Pharmacy. It also requires that every dispenser and prescriber, except veterinarians, register with the PDMP. We also have Code 54-1725A that outlines the requirements for obtaining the practitioner controlled substance registration. And then the requirement to query the PDMP before prescribing certain controlled substances under certain circumstances, and I'll get into a little more detail with that a little bit later, is set forth in Idaho Code 37-2722F. And another name for that query would be a patient prescription history request. That's what we commonly call it. 37-2726 allows the PDMP to gather information on all dispensed controlled substances and opioid antagonists for humans in Idaho. And that comes in handy a little bit later too. And then we have 37-2730A that further details that the Board of Pharmacy maintains a program to track the dispensations. And this is used to assist in identifying illegal activity related to the dispensing of controlled substances and providing information to patients, practitioners, and pharmacists to help prevent the inappropriate use of controlled substances. And I'll discuss that in further detail as well. Okay, so pharmacy reporting. In the Board of Pharmacy world, the term drug outlet refers to a pharmacy. And there's three main types of drug outlets. We have a non-resident, also known as an out-of-state pharmacy. And then we have resident drug outlets, which are in-state. And then we have prescriber drug outlets. And you can think of these as pharmacies run by prescribers in their offices. Drug outlets that dispense controlled substances must report to the PDMP by the end of each business day, providing prescription histories accessible to the individual account holders. So that's how you get your information when you're doing your queries. So on mandatory checking, I'm going to run through a couple of tools for you to access to show you where they're at. So we have on our webpage, we are available on the Doppel website under the Board of Pharmacy section. And on the PDMP webpage, we offer quick, easy tools to register and use the PDMP AwareX system. To access individual account information, an inquirer would select the AwareX individual PDMP account navigation button from this particular screen. And for your reference, this slide does provide links to the PDMP webpage, and a PDF version of this presentation will also be available. So once on the AwareX individual account page within the PDMP, you will find a login registration link that takes you directly to the AwareX program. There's also a link into the PDMP AwareX Support Center, which is the user guide for the individuals. And then there are three remaining resources on this page. There's a step-by-step guide for new prescribers regarding the registration process for PDMP, the practitioner controlled substance registration, and the DEA registration. This can be an incredibly confusing process. So I do send this out quite a bit. So unfortunately, we don't have control over posting that like at the DEA, for example, or on the Board of Pharmacy's page. So we have it here, but I do send this out quite a bit, and the people that are registering do find this quite helpful. We also have an FAQ regarding mandatory law and information on prescriber drug delegates, which I will get into that shortly. And then there's a NARCS Care application review. This is a graph tool that it kind of summarizes the prescription history information within the patient's account. Okay, our vendor for the PDMP program is transitioning all of their guides to online access. So the user guide for the PMP or WareX system is one of them. What is shown in this slide is only a snapshot of what is available. You can also get help with logging into an account and resetting your password, how to navigate the PMP Aware system, and how to create and review a patient's prescription history report. So, as indicated in Idaho Statute 37-2722, before issuing a patient prescription for outpatient use for an opioid analgesic or a benzodiazepine listed in Schedules 2, 3, or 4, the prescriber or the prescriber's delegate shall review the patient's prescription drug history for the preceding 12 months from the prescription drug monitoring program and evaluate that data for indicators of prescription drug diversion or misuse. Of course, we have some exceptions. The review is not required for patients that are receiving treatments in an inpatient setting or at the scene of an emergency or in an ambulance, in hospice care, or in a skilled nursing home care facility. And also there's another exception for a prescription that is written in a quantity intended to last no more than 3 days. I want to share an insightful story. I'm not sure if there are any dentists that are present today, but even if they aren't, I think this information is insightful and can apply to any prescriber. Not too long ago, we discovered that a patient exploited the law's prescription exemption for quantities intended to last no more than 3 days. They claimed a legitimate dental need, and this individual persuaded 126 dentists in Idaho to prescribe controlled substances within a short period. So while the law provides a 3-day exemption from checking a patient's prescription history, we encourage you to check the PDMP anyways so that similar behavior is prevented. So the information in the PDMP system is heavily protected, especially regarding who can have access. As part of that protection, Idaho law also prohibits access to the information outside the scope of practice, which is, as a prescriber, you have an obligation to protect, and anybody that has an account for that matter. Here's some examples of some high-profile examples of use outside of the scope of practice. Stephen Paddock, the Las Vegas shooter, his prescription history was accessed by a pharmacist and sold to TMZ. Similarly, information on Prince and Michael Jackson was also accessed illegally. Some examples of use outside of the scope of practice are looking at prescription histories for family members, romantic or not so romantic acquaintances, and employers searching for their employees. Those are strictly prohibited actions within the PDMP. Okay, so now I'm going to touch on some checking rates, and hopefully these screens are big enough for you to see. So some statistics here. This is from May. The top part of this chart splits checking rates into 2 categories, overall and group checking rates. And for each of the categories and their subtypes, percentage rates are also provided for all-time best checking month, and 4-month average checking data. Then at the bottom of the chart, the mandatory use comparison chart provides percentage rates for all-time best and the most two recent monthly checking rates. In May, we can see a slight increase in the providers in the 100% compliance. This represents an increase of 0.31% from the previous month. These rates may seem low. However, we are seeing a decrease in the number of prescribers who don't check at all. That said, it is important to note that these checking rates remain significantly below the 100% compliance that is required by the law. We also have, according to our law 37-2730A, the division can share unsolicited information with pharmacists and healthcare practitioners. So to facilitate this, we send monthly reports to prescribers of patients receiving controlled substance medications from 4 or more prescribers and have filled prescriptions at 2 or more pharmacies. So this chart has 2 categories, overall and professions that are notified. The overall section shows the number of patients reported, and like the previous chart, provides information on 4-month averages and changes. The professions notified section contains a breakdown of the number of patients reported for each profession with 4-month averages and changes. So at this point in the presentation, you might wonder how best to fit checking patient prescription histories into your already busy days. PDMP has some tools that will significantly save you time. Gateway integration is a service that allows automatic access to patient PDMP information within the electronic health records of your clinical workflow. Through integration, the prescriber can stay in their electronic health record system to review a patient's prescription history. The time saved by not having to sign directly into the PDMP AwareX could be beneficial for your busy day. This slide illustrates how integration significantly reduces the number of steps required to check a patient's prescription history, resulting in substantial time saving. Information on how to get set up for the integration can be found on the website on the PDMP page. I'm also available to assist in any way that I can, and I do strongly encourage prescribers to consider adopting integration into their practice. This chart here shows how we have increased participation with integration. We began offering this integration in 2020, and since its inception, participation has increased steadily. We are currently at an all-time high of 82.48% participation, so I'm pretty excited about that. We do reach out every year. We have campaigns to reach out, and we're going to continue to do that. Okay, so a couple of things here, final things to wrap up my presentation. It would be delegates and checking. So we do, in regards to checking, we do allow what we call discretionary compliance to give prescribers flexibility in accessing patient reports. And they can be reviewed up to 5 days before a patient's appointment. So when we're looking for mandatory compliance, that we do give that flexibility of that 5 days prior for a prescriber to look at those reports before prescribing. For prescribers that don't prefer the integration, that is something that doesn't work out for them. It is not for everybody, but as you can tell from that previous chart, it is for a lot of people. You can assign delegates to pull patient prescription history reports on your behalf via the PDMP AwareX system. So the definition of delegates is evolving. We will continue to include current health profession students and pharmacy technicians in that. However, starting July 1st this year, we will revise the eligible delegate language from nurse and medical assistants or office assistant to now be healthcare staff. Delegate PDMP registration takes about 2 minutes to submit. When setting up the registration for security purposes, the delegate must use their work email address, and the prescriber will receive an email from the PDMP system informing them that they have a pending delegate, and the prescriber will need to approve that delegate. So after the account is activated, some important things to note. Is using another person's PDMP account is prohibited explicitly in Idaho law. So delegates must use their account to pull patient reports. It's not okay for them to just sign into a prescriber's account and look up the histories there. Also, for the prescriber to get proper credit under the mandatory use law, be sure that your delegate specifically checks you off as the person that they're pulling the report for. Okay, thank you for your time and attention today. This does conclude my presentation on the PDMP program, and I'll stand for questions.
Looks like we have a question from Ian Troselier.
Hey, Wendy, thanks so much for the presentation. So I was trying to look at my compliance, and I'm at 0%, but I know that's not true. I'm trying to figure out what I'm doing wrong. So I'm not going to show any patient information, but can I share a screen, and can you tell me what I might be doing wrong?
It would probably be best if we just if you reach out to me, and then we can discuss it. I know that we had a compliance tool that we had purchased from our vendor, and it was not good. So we have pulled that off the system.
Okay.
So I'm curious as to what you're looking at, and yes, I can help you out with that. But if you would reach out to me, we can definitely dig into that.
Okay, that sounds good. Yeah, what I'm doing is in idaho.pmpaware.net. I'm going into the menu, and then under data, it says mandatory use, and there's a spot to generate a report. When I click into that for it to generate a report for me, it says that I've prescribed one controlled substance in the last 2 years, and I didn't check the PDMP for that one prescription, and so it says I have 0% compliance, but I have a really consistent habit of checking every time. So I'm like, man, I think there must be something going on with my account. And then when I look at my prescriber report, then it's more congruent. Yeah, I can see, oh yeah, I prescribe buprenorphine really frequently, and then but most of the other things I don't prescribe very often. And yeah, so I know that I should have more data on there about compliance. Yeah, so I would really appreciate, yeah, I'll touch base with you at some point one-to-one and see what's going on.
Well, I think you're heading the right direction, because that mandatory use tool, that's the one that we're pulling off. They may not have officially pulled it off, but effective July 1st, it should no longer be out there for you to use. Even 100% compliance prescribers at one point were seeing like 58 or 68% checking rates. So yeah, we decided not to pay them for a service that wasn't going to benefit our prescribers. But the other tool that you're using, the prescribing history, that's where you need to go to look at that. But yes, definitely reach out to me.
Okay, cool. I will send you a direct message with my contact information. Thanks so much, Wendy.
Yeah, you're welcome.
Thanks, Ian, for asking a question. I did put a survey in the chat. It's our post survey. So if everybody would be willing to click that link, these surveys are anonymous, and answer our post survey. We did have a question come in the chat, and we did answer it to the chat, but I do just want to briefly talk about it. It came in from Kendra. So Kendra, if you're still on and have additional questions, please feel free to unmute and we can talk about it. But the question was, what is the support treatment for xylazine and medetomidine if Narcan doesn't work? And is there a way to recognize it? So naloxone is approved for human consumption because and it works on opioids, right? There is no human, no medication approved for human consumption to reverse the effects of xylazine and medetomidine because they are not human substances. They are veterinary substances. And so unfortunately, there is no support treatment or human reversal agent for those two substances. A way to recognize if somebody has consumed xylazine and medetomidine is the things like the necrosis or the wounds, the ulcers. We didn't put any pictures in the slides. You can look them up. They're quite hard to be treated. And sometimes people, if they're using illicit drugs, will then inject into that wound, which makes the wound care even harder. We also, Liz and myself, put some links in the chat. And then just something as well to be aware of. You guys may have patients who at one point in time received a prescription medication, and then for one reason or the other, that prescription was not filled anymore. And what we're seeing is that people are going to the street and buying what they believe are prescription medications because though illegal, they feel like it's a safer option than buying an illicit substance. The Drug Enforcement Agency tests the pills that are seized and sent to them, and they actually tell us that 5 out of every 10 counterfeit pills contain 2 milligrams or more of illicit fentanyl in them. And they could have a lot of other things. So it could have different substances, either illicit or like some of these veterinary medications. But just something to be aware of if you know of a patient who does no longer qualify for a substance, talking to them about other ways. If you no longer can provide an opioid to that person, or you realize through the PDMP checks that they're misusing a prescription opioid, you can talk to them about alternative pain management options. Because if they're choosing to turn to the street to buy what they think is a prescription substance, they may actually be receiving a counterfeit pill that looks like the prescription, and they may think it's a safer option, but it's really dangerous for individuals. So just something to be aware of. And Kendra, I hope we answered that question for you. Does anybody else have any questions on either specific resources? Oh, perfect. Thanks, Kendra. Specific resources or any other questions? Like Ian, you had a great question. Anyone have anything for us today?
As another question, just knowing that Southeastern Idaho, our health district is really high as far as like prescriber rates. This question is for Wendy, but it's for anybody. Is there any action that like PDMP or Department of Health and Welfare is taking specifically to try to reduce prescribing rates in our health district, or what can you do to reduce those prescribing rates in our area? Mostly just education, or do you like reach out to providers directly when they're a significant outlier and say, hey, justify this?
I can tell you from a PDMP perspective that there's not any statutory law that says that we can do anything about that. And we look at the PDMP as a educational reference tool for prescribers. So I think what we're doing today is how we're using that information to reach out, and I'll let Morgan or Mallory talk about that a little bit more.
Totally. I mean, yeah, I think this education is really invaluable. I just think like if someone is obliviously like not realizing that they're, 2 standard deviations above like the normal for like opioid prescribing. I mean, not that that's super likely, but maybe there's somebody out there that's like prescribing a lot more than usual and be like, hey, you are a lot, what's going on with your patient population? Is it like a bunch of people with serious chronic pain, or is there some more direct one-on-one education that could be provided?
I'm not aware of any happening now. I know that we have our unsolicited letter that I talked about in my presentation, that we do that. So hopefully that will tap into some of those areas. But I can tell you that staffing for PDMP is pretty small. It's me and one other person, so there's only so much we can do. Investigations, we do cross over to them a little bit, but that's usually when there's a violation of law. So we're
Right.
limited on that.
Incredibly valuable tool. Yeah, I mean, especially with only like 2 people on staff, it sounds like. So really appreciate what you're doing.
Thank you. I appreciate that. Thanks for attending.
Just to piggyback on what Wendy said, yeah, we as we started to look at some of these rates over the last couple of years, we identified opportunity to just spread awareness. And so that's kind of our first step right now, is just raising awareness, bringing to light the fact that we do have higher than average dispensing rates in our area and certain pockets of the state. And then, talking about, the tools to mitigate that, using the PDMP, but also just looking at prescribing guidelines from the CDC, and then just risk mitigation tools as well, making sure that people actually, have the tools to prevent overdose if they're being prescribed, an opioid. And so that's a really good question, Ian. I would say this is like our first step, and hopefully we can make this even bigger. We're exploring doing this at a larger statewide level in the future as well. So stay tuned.
Awesome. Thank you.
Yeah, and just to also piggyback on that, we really do appreciate those of you who are on this call today. We know you are a very small portion of our prescriber or medical, population in the area, and so we really appreciate you guys coming on and being proactive, because we can reach out and send things out, but really you guys coming and attending and being willing and open to hear the information and learning how we can support and learning about community resources is really one of the most important things. And so we appreciate you guys taking the time. We are hoping that we can, like Morgan said, Morgan, Wendy, and I have talked, and we're hoping that we can do this presentation again and continue to expand it throughout the state and offer additional education and additional training. I know in Eastern Idaho, we go to a lot of our pharmacies and our different, we're working on going to different provider offices and making sure that they have our free resources like the deter drug deactivation pouches in their office. And then we give them education there if they need it and ask for it. But really, you guys taking the time out of your day today to come really means a lot to us. And I think it shows how much you care about your guys' agencies and organizations and the clients and the patients that you serve. And so we appreciate you coming and being on here today on behalf of your agency, but also on behalf of the people that you're serving and the community you serve.
All right, we have just 2 minutes left in our webinar. I did share my screen again, so there's the QR code to that post survey. If you haven't yet and you're able, we'd really appreciate it if you're able to fill out that brief survey for us. That helps us improve these for future audiences. And that's all we have for you today. Thank you all so much, and enjoy the rest of your week.